We'll go on to the first speaker. Yeah. Uh, okay. First talk is by Dr. Kundlu. All of us know him. Nice guy, fantastic person, and he'll be talking about mix and match IULs.
Thank you, Maipal sir, for nice introduction, respected chairperson, and my dear friends. Uh, so I'll be talking about mix and match IOLs, the combination of extended depth of focus and multifocal IOLs. This is my financial disclosure, consultant for Carl Zeiss India. As you know that the natural crystalline lens has got a good accommodation, clear vision at all distance, greater contrast sensitivity with no rotational asymmetry. My question to all my friends, can an intraocular lens can do the similar job as the crystalline lens? There is the still question mark. So coming to the multifocal intraocular lens, we have been practicing these lenses which have got a gradual diffractive steps on the intraocular lens implant that create a smooth transition between the focal points. Normally you will have a very good near vision acuity and a moderately good contrast sensitivity at all distances. Basically, these multifocal intraocular lenses are bifocals that provide a very good distance and near vision. But the active lifestyle requirement also is very important. Then come to the picture, nothing but the intermediate vision. So because of this intermediate vision, now the trifocals has come into the market. So coming to the what exactly is the mix and match, the patient should have a strong desire to have a spectacle independence. Normally in my practice, I operate between the patient of between 35 to 75. But it's very important to ask the patient about the hobbies like painting or whether he is a unusual avid reader. So if the patient is also if they are like for such patient even a short term glare and halos will be very intolerable. For such patient I still feel that the monofocal is the best option, but once again if you put a monofocal for this such patient, they may find difficulty in viewing the panel skin while they are riding their vehicle. So coming to the multifocal and idiopathic patients, the patients who beside having a cataract removed, basically they want to have a more spectacle independence. These are the candidate for this one. So I am talking about these lenses actually AT LISA platform which has been from the last 7-8 years. Basically these lenses are pupil independent 4 haptic lenses and contain a diffractive rinse until the IOL periphery. So coming to the multifocal lens about the AT LISA, I have been practicing these lenses for last 12 years. Basically it's a distant dominant diffractive IOL. Normally the distribution is light 65% for distance and 35% for near with a pseudo accommodative range up to 4 diopters. So basically these lenses are due to the asymmetrical distribution, it has got achieved a very high light yield. So contrast sensitivity also much better. This is a small video of AT LISA I have been doing. So this is a video of toric multifocal. Now the company stopped, they got into a trifocal platform, but these lenses are time tested lenses and the results are quite good. That time we are not exposed to this. One of my old video, I used to even implant toric multifocal almost at 10 years before. So coming to the contrast sensitivity, both in mesopic and different condition, you can see the pupil size. These lenses behave really well. These are the advantage with these lenses. Basically it's a light is distributed asymmetrically, which is independent of pupil size. The lenses made in something called SMP technology and also aberration controlling optimized aspheric optic. So coming to the EDOF lenses, the basic concept of EDOF lens is a compromise of benefits of both monofocal and multifocal intraocular lens. That means it is more spectacle independence compared to the monofocal intraocular lens with fewer side effect which is compared to the multifocal IOLs. So especially these are been implanted in the patient with a much sensitive to visual field. They don't mind wearing glasses for a very small print. So this is about the SMP technology. There is a smooth microphase technology. These lenses has been manufactured because of this technology that reduces the glare and halos. So coming to the advantage of this, especially I am talking about the AT LARA lenses from Zeiss. The advantage is these lenses are less sensitive for decentration and tilt, and it which widens the focus range of 3 focus planes that supports a continuous focus extension from far to the intermediate. And because of its neutral sphericity, it does not interfere with the corneal higher order aberration. Even I had implanted in the post-LASIK patient. This is the advantage. These lenses go through 2 mm very easily. It is a 4 haptic design. The one most greatest advantage of these lenses, even though it's a hydrophilic lenses, these lenses has got 360-degree anti-PCO ring that prevents the PCO formation. So this is the first lens actually I implanted. I think now lot of lens have been coming to the market with the EDOF platform, even in the refractive platform. I think Dr. Maipal sir do agree. He has been better experience. He always been telling the best option for treatment of presbyopias intraocular lens compared to any other option. But this was the video I have done initial first few the lenses with the 4 haptic lenses. So normally when you are implanting any of this multifocal or trifocal, it's very important you have to make a good rexis, that is around 4 to 5 mm rexis, and this lenses normally make sure that it is exactly in the coinciding in the Purkinje image of the central ring of the any of these lenses. So basically these lenses are excellent compromise of benefits of both monofocal and multifocal intraocular lens, more spectacle independence compared to monofocal intraocular lens with a fewer side effect compared to the multifocal intraocular lens. So in the end, I want to stress here about the neural adaptation, the process that takes place at the brain that adapts to change the visual information being supplied by the eye to the optical system. So I want to just once again tell about the visual complaints are not related to the aberrations, they are related to the neural adaptation. The success of a patient outcome continues to improve because of they have been adapted these aberrations. So this is our experience actually what we did. I myself checked for the dominant eye. I implanted the extended depth of focus lens in the dominant eye and implanted the multifocal lens in the non-dominant eye. My results, more than 90% of the patient had a very good distance intermediate vision from the dominant, and non-dominant eye gives a additional of near vision. So they will have a 4 range of vision, and all my patient has no glare and halo shadowing effect. The patient also come for a follow-up almost now 6 months to 1 year, and extremely very happy patient. In conclusion, with this combination with the dominant eye EDOF and non-dominant eye multifocal lens, you can even try dominant eye with even I have done in the patient with the dominant with the monofocal and non-dominant with the multifocal, still patient do very well. 90% of the patients are very satisfied for distance, as EDOF lenses give excellent distance and intermediate vision. Adding a multifocal to the non-dominant eye helps in near vision. More than 90% of the patients are spectacle independent. Hardly any complaint of glare and halo shadowing or halos are seen, as the design quality of the IOL makes it comfortable for the patient. Long-term follow-up must be seen, as the results are quite promising. Once again, I thank for the Chairman Scientific Committee and whole team for this opportunity. Thank you one and all.
Thank you, Dr. Krishnapal Kullu. I'll invite Dr. Ankit Agarwal. Is he here? Yes. So please put up. You can put it on this. And the next speaker is Dr. Sujata Mohan. I think since you set up our laptop on this side. And just only 2 comments for those who go for the multifocal IOLs. The acceptance for these IOLs is now very high because of less loss of light and less glare and halos, and recognition of important sight so that the patient can read better for near.
Okay. Good evening, everyone, and thank you, AIOS Scientific Committee, for giving me this opportunity. The topic is phacoemulsification, easy for beginners. In this topic, I will be explaining about the hemisphere chop, which I do normally, which involves very less power. Nucleotomy is the crux of any phacoemulsification surgery, as that is what separates it from MSICS. For any beginner, while advancing to phacoemulsification from ECC or MSICS, the biggest challenge is to use the phaco machine, that is, in the phaco power, which is used to do nucleotomy. Rest of the steps like rexis and IOL delivery are mostly similar. Now, what are the complications that may happen during nucleotomy? They are PC rent, corneal endothelium damage, and rhexis margin tear due to capsular margin getting caught in the chopper. In the following slides, I will try to demonstrate my technique of nucleotomy, which help reduce these complications during the learning phase of my phacoemulsification surgery. Now, making the groove. After finishing the rhexis and hydrodissection part, the first step which I do is making a central deep groove in the nucleus. For this, the settings which I normally use are aspiration of 20, vacuum of 100, and power of 60 to 100, depends on the hardness of the nucleus. Now, we should remember that the depth of the groove should be about 80 to 90% of the depth of the nucleus, which for an easy way, we can see that it's about 1 to 1.5 times the size of the tip. And it can also be determined, if you have a good microscope, by the red glow of the retina, which can be seen at the depth of the tip. The second part of an important tip here is that the groove should be boat shaped. That is, in the periphery, it should be shallower, in the center, it should be deeper, as that is how the nucleus is. Second part, hemisphere separation. Here, the two halves of the nucleus are separated. Now, there are two methods. One is the manual method, wherein after filling the AC with viscoelastics, we can use two Sinskey hooks, a chopper or a Sinskey hook, to separate it manually. Herein, we have to insert the two Sinskey hooks to the two side ports and keep their ends at as deep possible in the groove as much and pull them apart, thus separating the two hemispheres. Now, the second method for slightly more advanced surgeons who have better pedal control is using one phaco tip and one chopper. That is, using the phaco tip with only aspiration mode on, we can separate the two pieces. The advantage of this technique of nuclear braking are less chances of corneal endothelium damage, as less phaco power is being used, and also nuclear pieces are not flying around. Low vacuum settings are used here when using phaco tip. Hence, chances of surge are lesser, which is very suitable for low-end machines also. Manual separation also reduces risk of inadvertent PCR occurring due to any uncontrolled phaco power being delivered while doing direct chop or stop and chop. Most of the instrument manipulation is done at the central area at a deep level, which is deepest, hence chances of instrument touch to cornea is also less. Now, next step is emulsifying and aspirating the two hemispheres which we have created. Now, after separating the nucleus into two pieces, one by one, each piece is emulsified and aspirated. During this junction, the settings which I normally use are 300 to 350 vacuum, 60 to 80 of power depending on the hardness of the nucleus, and 34 to 38 of aspiration. These settings are variable depending on the type of machine. Like in a low-end machine, I will keep my aspiration and vacuum settings at a lower end, while on a high-end machine, we can keep them higher due to chances of surge are lesser in them. At the end of this process, a rim of cortex remains, which is cleared using irrigation aspiration, and IOL is placed in the bag. Thus, the take-home method is no power chop is a very easy method of nuclear separation in phacoemulsification, which is reproducible by most phaco surgeons, even beginners. In this technique, the chances of PCR and corneal damage during chopping are greatly reduced. And if by some chance PCR does occur, then because there is not much inflow or outflow from the AC, and AC is filled with viscoelastics, vitreous prolapse is minimal, and also chances of nuclear pieces falling into the vitreous are lesser. And this case can be easily converted to MSICS or ECC and managed. Thank you.
Thank you, Dr. Ankit. I mean, this is a traditional, what we call as a stop and chop.
Yes, sir.
So
But true, this is a very traditional method, but nowadays a lot of insistence is being done on direct chop and using phaco tip to chop basically more. So I was just...
So there are just only one or two suggestions that, first of all, I am all for what we call as a stop and chop technique, because if you are comfortable with this technique,
do not feel that the direct chop is superior than this, because all the energy delivered for making a trench causes no collateral damage.
Yes, sir.
Though you are using more phaco energy, but it is far away from the
Far from the
cornea.
cornea. Yes, sir.
So it causes no collateral damage. Secondly, when you are bringing the probe back, trying the probe, that time your foot pedal should be power should be off.
Power
and when you are
off.
going forward, your power should be on.
Yes, sir.
Your incision was little more corneal. It should be little on the whiter side, where the limbus
More
was
limbal.
little more anterior.
Okay.
And the width of the trench was not adequate, so far as I am concerned. Although you mentioned that there should be more deeper trench in the center, but your trench was more deep in the periphery than it was in the center. Because if your width of the trench was just one tip wide, and the sleeve keeps on obstructing, and you're not able to reach to the depth of the nucleus. So the trench from the superficial side should be little wider, so that the sleeve can be accommodated when you are trenching, and the trench should be deeper at the center. So this patient had not so much of a leathery fibers, so it becomes very, very crucial when you are dealing with the
Very hard cataracts.
Yes,
Yes.
Otherwise, it's an excellent technique, and it works for all density of the cataract, from the hardest to the softest. This technique can be adopted. Thank you very much for bringing out. Nice. So next is Dr. Sujata Mohan, and she'll be talking about Snow White cataract management.
It's already loaded in that.
Yes, ma'am. हेलो भैया,
It's not here.
हेलो भैया, वो कैसे लाना है वो विंडो आर के बाद? यस सर।
Snow White cataract.
हाँ
Snow White cataract.
हाँ कर दिया, पर ये आ रहा है दिया नहीं आ रहा है, इसमें नहीं आ रहा। विंडोज कैन नॉट एक्सेस। अरे अरे भैया, मैम खड़ी है, देना है मैम खड़ी है, प्रेजेंटेशन देना भैया।
I think the next speaker, let them get the study is having some problem.
वो ओपन नहीं हो रही ना, उसमें नहीं है।
Shall I put that and play?
इसमें
Can I just load it and
हाँ
then?
मैम, हाँ हाँ मैम।
Okay, thank you, sir. It's a privilege to talk in front of all the accomplished phaco surgeons. I'm predominantly a VR surgeon, doing to some extent a bit of a phaco work. It's not showing on my screen. I have to look there and speak. Okay. Well, this is one of the most traumatic cataract. Cataract is one of the commonest causes of unilateral blindness in young. And you can see the rosette or the stellate pattern is basically the pattern which is more classically described in cases of trauma. The speciality of this particular thing is that cataract usually does not exist all alone. It is also associated with anterior segment comorbidities in the form of iridodialysis. You have zonular dehiscence, you have a PCTR, you might have a foreign body or a vitreous herniation, as you see here. And sometimes it is also associated with comorbidity in the posterior segment in the form of vitreous hemorrhage, detachment, macular hole, RPTR, and all those comorbidities. And that is the importance in such cases, is just don't look at the cataract and jump for a cataract surgery. You should assess in toto these particular cases. So evaluation of cataract is equally important, and the challenge begins right from the posterior segment involvement. You have to do a B scan whenever there is no adequate view of the posterior segment, where you can surprisingly pick up a large posterior scleral tear. You can see a collapsed deferred globe. You can see a choroidal detachment, which are suggestive of posterior scleral rupture. And associated ocular morbidities in the form of a lens drop, a foreign body, a vitreous hemorrhage, and retinal detachment will totally change how we are going to approach this particular case. Now, this is a case which had a blunt injury, and you can see the nucleus just behind the posterior capsule. This is how a B scan can change, and here comes the role of a vitreoretinal surgeon. Well, coming to the management, yeah, if it is a small stationary peripheral opacity away from the visual axis, it can be just watched. But if it is in the center involving, well, it needs to be managed. So how do we do? Whether it should be done at the time of a primary repair or it should be a two-step procedure. Single step procedure should be done whenever there is a fear of a intraocular foreign body posterior segment injury, whenever there is a also involvement of infection. In such cases you should be doing a common, but the limitation in such cases is the biometry of fellow eye, and sometimes it is difficult to predict whether should we put a IOL along with it, because if there is any evidence of inflammation, it is better not to put any other foreign body inside the eye. So this is a case of a cataract removal with a primary repair. So after removal, well, in such cases the cataract is really soft. You don't have to do simple irrigation aspiration, and you put the lens and put it in the sulcus or in the bag. If the posterior capsule is maintained, then it is easier. Well, majority of the times when the tear is quite irregular, and in such cases you can do it as a two-step procedure. The advantage is two-step procedure, as you get a quiet eye, you can do a keratometry which can give you better prediction of the IOL power. But yes, the limitation is that if it is done over a period of time, it can lead to amblyopia, especially in young. And it means you have to do two steps, means later rehabilitation. So what are the treatment options once you have a traumatic cataract? These are the various options. Lensectomy you have to do along with a primary repair whenever there is an involvement of posterior segment in the form of posterior capsular tear, vitreous hemorrhage, or a foreign body. Phacoemulsification, well, usually the advantage is because of a soft cataract, here in such cases you don't have to do much. Simple parameters which I have provided, I will just run through. What should be the choice of IOL? Yeah, preferably where should it be placed? It should be placed in the back if possible, if the capsule you could preserve. But if not, second procedure place of choice is going to be in the sulcus. Never put a iris supported lenses in such cases, basically because unless you are sure about the infection, further adding to inflammation of the uveal tissue is not suggested. So these are some of the challenges. The biometry challenges, because of the corneal tear you cannot have a proper keratometry, and in such cases these are the treatment options how you do ahead. Then coming to various challenges, these are the corneal challenges where you have some peripheral corneal opacity. Well, the treatment option is similar, you do a rhexis. But if in such a case siderotic cataract which is done on a 3D system, you use certain filters to bypass the involvement of a corneal haze. And in a central corneal opacity, well, you have to rely on the posterior glow by moving the eye and getting the glow, and against it operating. So you have such a central opacity. These are the various treatment strategies. Sometimes you can use an endo-illuminator to be put into the vitreous cavity to have a posterior glow in such cases. You have a iridocorneal adhesions, they need to be separated either by using a cannula, by sometimes using a visco expressions, and by using a irrigation aspiration probe. And this is how various techniques are done. The other challenge is about the pupil, which can be either, in this case you have a pupillary membrane with posterior 360-degree synechia. Here I am doing a synechialysis with the help of irrigation aspiration tube, and once that is done and the AC is deepened, the rest part becomes quite easier. Then these are the capsule related. You have an anterior capsular challenge. Well, here you have a tear, and here the challenge is to convert the same pre-existing tear as a nick and convert it into a rhexis. If it is a small tear, well, you can manage such cases. But sometimes a central capsular fibrosis, in such cases, again, you have to go beyond the capsular fibrosis to manage a rhexis. But there are certain situations. In this case, you would see the capsular fibrosis is quite significant. We had almost a 8 to 10 millimeter size rhexis, and after doing the nucleus, you will see in this particular case, I cannot forward the videos over here. So, and then the lens was put in here. And this case, anterior capsular fibrosis was so strong and it was extending much beyond the pupillary margin. We had to use Vanna scissors to cut it off and then get whatever best amount of anterior capsular preservation we could do, and then the rest steps were quite easier. Now here in this particular case, you see the capsular fibrosis is quite beyond the pupillary margin. So whatever we did, we tried to do and manage the rhexis with the help of a scissor as well as doing. Then after doing the phacoemulsification, I thought I'm seeing some capsular ring in the periphery, and to our surprise, this was a totally calcified capsular ring beyond the nucleus. So such surprises when you're managing a traumatic cataract are not uncommon. And this is the, you see that particular calcified cortex in the periphery which had to be removed. Then the posterior capsular challenges, well, sometimes you should be anticipating thing. You do a B scan, but sometimes you are caught unaware, and then you should be ready to challenge it by having a vitreoretinal surgeon who will go through the posterior chamber, through the pars plana and cutting the vitreous, and then putting the lens in the sulcus. Well, this was a phaco which we were doing in a case of a doubtful posterior capsule rupture. This was a case which has undergone vitrectomy, and so sudden intumescence in an eye which has undergone vitrectomy, you should be means having a doubt about having a posterior capsular deficiency. And so we did a phaco and then put the lens, and then we had to go behind. Well, these are certain cases where you see this is the pre-op case of a posterior capsular dehiscence and the nucleus was behind. So here the primary approach is going to be from the pars plana. You have to do vitrectomy, do the lensectomy and remove that. And once that is done, you have to place the lens on the anterior capsular support because the posterior capsular was dehiscent. And after we put it, we did a primary posterior capsulotomy into the anterior capsule. So this is how this is pre-op of day 1 and post-op. Sometimes the challenges can be to an anterior segment surgeon is because of lack of glow if there is a presence of a hemorrhage or and in such cases doing a capsulorhexis itself becomes a challenge with a media haze and all. So in a 3D visualization systems you have filters which allow you to have a look, or sometimes you use various endo illuminators to have this. Then the position related changes, some plaque-setted lenses you have which need to be tackled along with a CTR. I will come to another case. This is a vitreous herniation in a AC case. Well, here I am doing anterior vitrectomy with the infusion cannula. Once I do anterior vitrectomy, then only I proceed doing a rhexis and then doing the rest of the steps. So every step has to be managed. And this is a traumatic case with aniridia. Well, this is a 180-degree disinsertion where I am getting it out of the active port. And once that is done, phaco is done, the iris root disinsertion has also to be done. So iris repair was done. And once we do an iris repair, this is the pre-op and the post-op. So just primary management of cataract per se is not important. This is another case where we did a pre-op total disinsertion of iris along with cataract. Yeah, yes, sir. And this is pre-op and this is the post-op where we did an iris repair as well. So you have sometimes associated retinal detachment in a myopic and sometimes with a vitreous hemorrhage and RD. So you should be doing a complete B scan and should be mentally ready to tackle. So it's a bouquet of cases where you will see that a cataract is not the only thing which you need to manage. You have to tackle the associated comorbidity, and that is the challenge, and you should assess your limitation and assess the amount of extent of involvement, and based on that you should be taking a call whether it should be done by a primary phaco surgeon or you should also take the help of a vitreoretinal surgeon. Thank you.
Thank you, Dr. Prashant. I think for bringing out so many points, and that itself points out that traumatic cataracts are really very, very challenging. Until you have got all the accessories and the competence of handling the iris issues, the posterior segment issues, and the variety of lenses available to you, you should really avoid operating these cases. So now we want to talk of Snow White cataract management by Dr.
Good evening, everybody. At the outset, I'd like to thank AIOC for giving me this opportunity. My video is totally recorded and it's got an audio. It plays for about 7 minutes. So here it goes. Volume I need. Volume. Audio. You switched on the audio? I think the audio is not working. Anyway, I'll just go through this presentation. So we have a myriad of different types of cataracts. This particular cataract is a intumescent flocculent cataract. It's a hypermature cataract. And this is a cataract with a hard nucleus. This is a cataract with a small pupil. So these different types of white cataracts are to be dealt with in a different way. And these can be additionally complicated by small pupils as well as by fibrosed anterior capsule. So each of them have to be dealt in a different way. So rhexis becomes probably the most important aspect of mature and intumescent cataract, and you can see the Argentinian flag sign. In these patients, it's always be prepared to prepare the eye preoperatively by using IV mannitol and giving a block if required, and making sure that the intracapsular pressure is reduced. So this is how you can see that the rhexis is extending on both sides. And if such situation happens and you are a capable phacosurgeon, you can extend the rhexis on both sides of the bridge and make it into a slightly larger area for you to do the phacoemulsification. And particularly if it's a soft cataract, you can do a gentle phacoemulsification without, taking care that you do not work in the area of where the rhexis deficiency is, and do a very slow motion phaco and remove the cortical matter as well as the nucleus, and then you can implant a lens inside. This is particularly only meant for surgeons who are very experienced. Alternatively, the most important thing is to prevent it. So here you can see this cataract. As soon as we enter, there's a lot of milky white matter coming out, and using an Utrata forceps, just do a centripetal rhexis, that is pulling the rhexis towards the center. So that's the best thing to do because it reduces the pressure of the capsular rhexis extending to the periphery. So this, once the rhexis is done, then it becomes very easy. This is again a case with a high flocculent cortex and a high intracapsular pressure. So here I'm using a 30 gauge needle to reduce the intracapsular contents. You can see that I have removed quite about 20% of the flocculent cortex. And once you have done that, then the rest of the job becomes easy. You can go ahead and do a rhexis very nicely without any extension of the rhexis. And then you can go ahead with your cataract surgery. This again is an intumescent cataract, and my go-to is using a 30 gauge needle. It's important you fill the bag with a high density viscoelastic like Viscoat. I have no financial interest. You can alternatively use sodium hyaluronate also. And once you have removed a large quantity of the flocculent cortex, then you can go ahead with the rhexis and complete the rhexis without the rhexis extending and creating a problem for you. All these patients are preferably done under parabulbar anesthesia. So this is a case with a femtocataract. Femtocataract is again a very important way of dealing with these hypermature cataracts. And the most important thing is just to make sure that you don't, there are some cut edges which may be left behind. And one of this, the newer advances is a zeptorhexis, where a nitinol ring is used to create a rhexis. And you get a free floating rhexis. So it's a great advantage, and this can be used, and it's a much cheaper option to femto. And the last and one of the most popular ones in our hospital particularly is that using the punchorhexis, where the phaco needle is used to punch not only the capsule but also to reduce the intracapsular pressure and punch the cortical matter as well as the nucleus. Thereby, in one go, it reduces the intracapsular pressure, and then you can go ahead with doing completing the rhexis. It's important that you use a Venturi machine and a 15-degree or a 0-degree trip. So patients who have smaller pupil or who have PAS will need iris hooks to enlarge and then you go ahead with the phacoemulsification. So once you start the rhexis, you can see there's a lot of cortical matter which is coming out. And the problem in this Morgagnian cataracts is the nucleus is extremely mobile. Once it becomes mobile, it's very difficult to do the phacoemulsification and becomes difficult to impale the nucleus. So it's because they keep rotating in the inside the capsular bag. So this is the lollipop technique, where you catch hold of the the nucleus like a lollipop and continue to chop all round. So I actually prefer to use 15 degree or 0 degree tip. In this, it's a 45 degree tip and becomes a little bit more difficult. This again is a patient who has had a mature cataract as well as a hard nucleus, say about grade 3 to grade 4. You can do a simple central trench and then do a karate chop. So at all points of time, you will be able to see the both the chopper as well as the phaco needle. And once you have chopped through and through, you can complete the surgery and insert the intraocular lens. So some of the most important tips that you have to learn in a mature cataract is, you have to assess what type of cataract you're dealing with, whether it's an intumescent cataract or a cataract which has got a milky white cortex, or cataract which is associated with the hard cataract, with the hard nucleus, and manage them. Probably the most difficult ones would be where the cataract is intumescent with a shallow anterior chamber, and these patients definitely require adequate care and preoperative as well as intraoperative management. If you take care of all these simple tips, then the results always come out very well and make the patient happy. Thank you. Yes. So we use high phaco power as well as phaco with 60-70, and as well as a good vacuum, 400 to 500 vacuum. So it just takes a matter of a second. With the blink of an eye, you just catch hold of the rexus as well as the nucleus. If you delay too long, then that also will start extending. That is one thing. And the second thing is, use only HPMC. Don't use any high density viscoelastic, because it will block the needle, the mouth of the needle, and so that's not in our favor. So in these situations, you just use an ordinary HPMC and enter and give a good punch. And once you have decompressed, then you can, the small rexus can be extended and made larger. I'm more of a proponent of a needle. I use a needle, 30 gauge needle, to remove it. Mohan does puncturexus more often. Almost all his cases he does puncturexus.
But one thing I will like to add now, just whenever you get a white cataract and you see on your operating microscope the small pockets of it over there, just do the massage of the lens capsule, which you can call as a lens massage or donut capsular axis, and you will see that the axis
flattens down. That is Chi Soon Fake also, she says she does a massage. But introducing a 30 gauge needle and then aspirating some of the cortical contents works out so well. It comes out very beautifully, and then it's much more easier, sir. And I think that is a surefire hit, because it cannot go wrong at all.
Thank you. Now we go to the next talk. Dr. Vibhuti Sinha will be talking about this surgical, phacoemulsification in small people, ways and means.
So, thank you, Chairman Scientific Committee, for giving me this opportunity. I'll be talking on phacoemulsification in small people and making the things easier for a novice surgeon, what exactly one should do. So no financial disclosures to be made. So the critical diameter is dependent upon the surgeon's skill and the technique, the intraoperative situations, and the RS tissue properties. RS tissue property is very important part of the maneuver which you do in cases of a small pupil surgery. So it can vary from 3 millimeter to 5 millimeter for different surgeons, but one need to remember that these cases are a little different from the normal cases. So one has to be prepared for dealing with multiple complications. So what are the causes? The causes could be pseudoexfoliation, past meiotic views, uveitis, and IFIS. I'll not be talking on IFIS. In this presentation, IFIS requires one presentation in itself. So the other causes could be iridocytes, anterior segment dysgenesis, and other thing. So what are the challenges in the small pupil phacoemulsification is reduce red reflexes while you do the phacoemulsification, increase risk of the iris damage, iris bleeding, prolapse from the wound, small anterior capsular exercise, which can make the life difficult during the rotation, or even in while you are doing the cortical aspiration or the epinuclear plate removal, anterior capsular damage, that is chopper tip can damage the anterior capsule, incomplete evacuation of the cortical matter, and problems in ensuing in the bag IOL placement if the IOL opens up little earlier and the visibility is little poorer. So if you don't do a proper pre-op evaluation, what can happen then? These are some of the complications. So minimal iris chaffing can occur. Next day you can see lot of edema, or if you are if you have a bad day, then you can land up into a drop kind of a nuclear situation. So breathing pupil, one has to remember, this is one important thing which is important from the point of biomechanical properties. If the biomechanical properties of the iris tissue is not proper, then this iris tends to fall during the surgery, and makes the life difficult for the surgeons. In patients with a poor property, they need devices and hooks. So current approaches, pharmacological and surgical. In the surgical techniques also, there are various techniques which we can employ. So in pharmacological approach, the proper pre-operative assessment, proper counseling on the operative day, the patient receiving the Medriatic and NSAIDs or atropine in cases of IFIS. During the intraoperative phase, also non-preserved epinephrine or intracameral epinephrine, which are available nowadays into the market, can be utilized for giving some kind of dilatation through which you can do the surgery. But in my personal practice, I try to avoid many of these chemicals because they can create task-like situation which we are right now dealing with. So the phacoemulsification technique is in the phacoemulsification, the important thing is make a long clear corneal incision, a little anterior corneal clear incision. Try to stay anterior rather than posterior. If you stay posteriorly, what will happen? The iris tends to prolapse and then things will be a little difficult. High molecular weight viscoelastic and an endocapsular vertical chopping phaco technique can be utilized. In the use viscoadaptive OVDs, decreased fluidic parameters has to be utilized during the surgeries so as to make the chamber little stable. Utilize a chop technique rather than a trenching technique and manipulate in the pupillary center. This is very important. If you do most of the manipulation into the pupillary plane, the chances of hurting the iris tissue is lesser, and that can give you space, and the iris will not try to revert back and tend to revert back with pupillary constrictions. Use of bimanual irrigation aspiration is more important because the coaxial usually it is little difficult. So in the surgical techniques, what are the other things which we can do? So one need to learn various techniques rather than going for just one technique. We can use saniculisis, iris stitching, iris cutting, and iris retaining devices. And these are basically meant for different surgical techniques, surgical scenarios also. Like in cases of uveitic cataract, we can do some kind of pupillary stitching, or the pupil is extremely rigid because of the pilocarpine or the meiotic use, or because of the post-inflammatory causes. Then we can do the stitching with a Kuglin hook and at the right angles to on two sides, and then that is going to give you a good kind of dilatation of approximately 5 millimeter to 6 millimeter. But only thing is that the post-operative, the cosmesis is not there, and sometimes the patient may complain of the glare. During the phacoemulsification period also, if the patient tissue property is not good, then they will fall very fast, and that will make the life difficult for the surgeon. So pupillary stitching is very important, but important thing is the complications. So complication is atonic pupil, chronic inflammation, CME, pupillary capture, and pigment deposition. Remember, if the tissue property is not good, like IFIS in cases of iridocytes, don't try to do this maneuvers whatsoever comes. So iris cutting devices can be used, like you can use a small Vanna scissors to do small nip into the pupillary margin, and that is again going to give you a good kind of the pupillary dilatations. A pair of Vanna scissors is good enough, but again, since you are touching the iris tissue, that can result into the transient constant IOP rise, increased inflammation, and CME. So one has to remember to control the post-operative inflammation in these cases. Pupil recovers with excellent physiological functions and cosmesis, but there is chances of increase in the CME cases. Then iris retaining and iris devices are there. Like first there are iris retractors, and there are iris retaining rings. Iris retractors can be used at the various planes, but only thing is to remember that that has to be at the plane of the pupillary.
Vibhuti, just run
So,
through.
just, yeah. So one has to use iris hook at the pupillary plane so that tenting is not there. So this is one device which one can use. Then there are good number of devices coming from the outside. Then there is another device which is Bhattacharjee BHEX ring, which can be utilized. And this is very good ring. Only thing is the insertion technique has to be learned very fast. This is a flexible jointless hexagonal device. And once you start using this device, you will love this device since it is a uniplanar kind of device and gives a good kind of dilatation for performing a good phacoemulsification. So to conclude, I'll not go through the videos. So to conclude, follow a stepwise approach is very important. So every step has to be followed by the next step, and one has to prepare multiple plans for every next steps. Give importance to the size of the pupil and the biomechanical property. Important thing is stay in the center, prepare the patient for a prolonged surgical time, reduce the number of entry and exit from the anterior chamber. That is also very important. Modulation is again important, and try not touching the iris as much as possible, and also not try to be blind. Do the blind procedure as far as possible, otherwise you may land up into a deep trouble. Thank you very much.
Thank you, Dr. Vibhuti. Now I invite Dr. Rajan. I think we're talking about unhappy patients after a cataract.
Thank you, Arbansh, and thank you, AIOS, for the wonderful opportunity. I'm going to talk about, can I have the first slide, please? Yeah, you able to see the slides there? Yeah, fine. These are my financial interests. As you know, the changing profile of the cataract patient, younger, active in life, more importantly, the expectations are very, very high as far as the vision is concerned. How many of you have had this problem? 6/6, N6, and the patient is unhappy? How many of you? I'm sure everybody has gone through this. I'll just go through some different case scenarios since we are running short of time. Refractive multifocal 6/5 N5 vision, long time back, 2003, 2004. You can see it's a rezoomed lens, beautiful rexes like a femtorexis, glare halos, and these are starbursts. It can be very troublesome to the patient. And what is important is a type C personality. When they see the glare and halos, they become type A personality. So that is a big problem. And this patient sued me, but fortunately for me, she died of myocardial infarction. Okay. Number 2 is 55-year-old female, Alcon Acrisoft lens. You can see patient not happy. What is the reason for this? You can see a crack on the lens. Can you see a crack on the lens? Okay. This intraoperatively, I noted this because one of the OT assistant don't hold the optic of the lens with the McPherson forceps or any forceps for the matter, whether it's a multifocal or unifocal lens, you can have a crack. I thought it was just a small mark there, but it had a crack, and patient had a polyopia and a light scatter, and she went to another ophthalmologist in Chennai, and that ophthalmologist said there are 2 cracks. One crack is on the lens, the other crack is the surgeon who's operated on you. So that is the thing. And she became very furious and she sued me, but I won the case for that. Just to show you that different types of multifocal lenses, we have a lot of problems. We need to know how to deal with this. Again, another patient with a multifocal lens, you can see here, this mainly because of the glistenings, which is very common with the Acrisoft lenses. The glistenings actually cause, especially in a multifocal lens, the Restore lens, which Restore +4 lens, which I used long time back, about 10-15 years back. You can see the glistenings can cause a decrease in the contrast sensitivity as well. So again, as you know, the glistenings can be a real problem. Again, another patient with multifocal lens, the decreased contrast. You can see what is happening is there is only a one line on the posterior capsule. But in a multifocal lens, this line is good enough for 2 or bad enough for them to have a decrease in the contrast vision or the visual acuity as well. So don't expect the posterior capsule opacification to occur. Even the YAG rates in the multifocal lens are much higher, not the posterior capsule opacification, but even if the line or the wrinkle on the posterior capsule, you can see there's a line on the, once I did the YAG laser capsulotomy, the patient became very happy as well. Again, patient not happy. Typically, the patient says, I was happy, my vision was very good. Past few days, it's not very good after a couple of weeks. And if you see that the fundus is fairly normal. So, I feel that OCT is a very, very important tool. Okay, because the OCT can pick up this OCT's CMEs, which normally in a clinical examination on 90 diopter, 70 diopter, or indirect ophthalmoscopy cannot do. But the patient is not happy. Very typically, they say decrease. Once you put the patient on non-steroidal anti-inflammatory napafenac and steroids, the patient become all right as well. Again, another patient with the thickness, residual astigmatism. If you have residual astigmatism multifocal lenses, they will kill you. Okay, and you see, this is one of the biggest problems. You can see another patient with the thickness multifocal plus 24.5 diopters, 618 N18. Okay, see the refractive or post-operative refractive plus 2.5 in the right eye, plus 2 in the left eye. Okay, if you make them myopic, they will just leave you. But if you make them hyperopic, they will decapitate you and bury you. Okay, so that's what they will do, because in hyperopia the problem is in a multifocal lens they will not be able to see distance, intermediate, reading when you have hyperopia. Why this hyperopia has occurred? Because of this dense asteroid hyalosis. This patient had dense asteroid hyalosis in both eyes. The OCT was normal. I made a mistake of going in for a multifocal in this patient. So if you have dense asteroid hyalosis, probably is not, because it alters the refractive index. You cannot get the proper lens for this patient. And multifocal probably would have been, say, I discussed this with Samuel Mascott, Warren Hill as well. You can see that it's one of the reasons. If you have dense asteroid, even the OCT macula is normal, don't go for multifocal because you cannot get the power of the lens properly. Again, a crystal lens, I was one of the largest users of crystal way back in 2008, 9 and 10. You can see crystal lens, what happens is a very good lens, accommodating lens. All of a sudden the crystal lens can move forward and talk. That's called the Z syndrome, and the patient can have a myopia. Again, another patient with a hydrophilic lens, three-zone refractive multifocal lens. Because of capsular phimosis, the multifocal became, shifted backward, and there was an hyperopic shift of the patient. Once they did a YAG laser capsulotomy, it became all right. Again, another patient, you can see the ocular surface. Look at the ocular surface in multifocal lenses. You need to optimize the ocular surface before you take these patients. But post-operatively also, you have to put them on lubricant, especially when they are using a lot of other drops as well. And ocular surface disease is one of the important things you can see. Again, another patient with a symphony. You can see here, this is a gynecologist, and she said, I am not able to differentiate between the ureter and uterus, which is a very common problem among gynecologists. I put a symphony, very happy, 6.5 N6 vision. But the problem is, she said, I've got this ring around the lensing. It's called negative dysphotopsia. I said, you have the other eye done, madam, you will be all right. Other eye done, again, what is happening? 2 negative dysphotopsias on both eyes, 2 semicircle. What do you do for these patients? Very difficult problem to treat. So fortunately for me, this patient, husband became very sick. She had a CA rectum. So she got distracted. I told her to wait for 3 months, 6 months. Husband became very sick, got distracted, and completely forgot about the negative dysphotopsia. Otherwise, very difficult to treat. I'm sure, I don't know what you do, Ramurthy, for negative dysphotopsia. Very difficult because you need to go in and probably do a reverse optic capture or probably do a capsulotomy or whatever it is, but very difficult. So this is one way of taking care. Give them another problem so that they'll get distracted when you have the negative dysphotopsia. Very, very the same. But because this occurs only if you have a perfectly done surgery. If you have a lens in the sulcus, you will not get negative dysphotopsia. If you have a lens in the back, perfectly done surgery, then you can have a problem. Okay. Again, another patient can see here post-operative picture. Again, the patient functional. You need to take care of the functional aspect. This eye, one eye was done by me. The other eye, it took only 5 minutes. The other eye was done by one of my assistants, and it took about 30-40 minutes. The patient, the patient is having 6.6 centrifugation, OCT is normal, eye trace is normal, everything is normal. Patient says, no, my left eye is having some problem, my right eye is better, whatever whichever eye I have done, you have done is better. So functional overlay is also important, but you need to make sure that you don't have any organic pathology before you label them as the functional overlay. Residual refractive error, PCO. PCO means not PCO, wrinkle on the PC or a line on the PC. CME, do a OCT, dry eye, MGD, ocular surface, decreased contrast because of glistenings, lens tilt, and also functional overlay. I'm sure you'll have a happy patient. Thank you very much for the wonderful opportunity and the patient attention as well.
So we come to the last part of the day, surgical management of lens-induced glaucoma. That will be covered by the Srini.
Thank you, sir. Good afternoon. First of all, let me congratulate behalf for organizing such a wonderful meeting. It's already a success. So, when you are discussing lens-induced glaucoma, these are the different conditions which cause the glaucoma. Among these, phacolytic and phacomorphic glaucomas are the most common, and I'll be discussing these in my presentation. So the definitive treatment for lens-induced glaucoma is cataract surgery, but you have to manage the inflammation and glaucoma as the patient is waiting for cataract surgery. A lot of challenges in cataract surgery in these cases. Many of these cases you'll have a shallow anterior chamber. Endothelium is frequently poor in these cases for many reasons, including the inflammation that is going on there. There will be challenges in management of anterior and posterior capsule. Frequently, the zonules are weak in these cases, and many of these cases, though it will be white, you will see a camouflage brown or black cataract underneath it. The video is not seen. material in the anterior chamber. Like once you wash it off, you will see the then brown nucleus underneath. So this is another problem. See, this is another case, phacolytic glaucoma. So I mean, you have to stain the anterior capsule with trypan blue in all these cases. You will. I'm not able to fast forward it. I mean, so this is once you wash off the trypan blue, you'll see it's nearly 90-degree zonal dialysis. So there might not be this much of zonal dialysis in all cases, but you can expect weak zonules in almost all the cases of lens-induced glaucoma. Another issue here is the anterior capsule running off to the periphery. Can I fast forward it? कुछ आगे करना है. वीडियो आगे करना है. कुछ नहीं आ रहा इधर. Okay, so it runs off to the periphery, and the way to manage it and prevent it is by planning two-stage rexes. Initially small rexes, decompress the back, and then enlarge the rexes. The only issue is it will take more time. So this is where you do. Ma'am has already shown this. So initially small rexes, decompress. I'll just go for the other one. So the basic idea is to have a small rexus in the beginning. Make sure that it stays at the center. All the movements should be towards the center to make sure that it doesn't run off to the periphery. So that is what is being done here. You can see the pull going on to the center, but you'll have a world champion appearing in no time. So if this happens, this is a well open area now. If you do phaco through that, it's definite that it's going to fall down. But if you make a rexus on both sides, you can cut it either with vanas or micro scissors, and make the rexus with utrata forceps or micro rexus forceps. So this is how you have to make space enough for a safe phacoemulsification. So I just wanted to show the orientation of intraocular, but it's going to, I'm not able to fast forward it. Let's go to the next one. So here again, the same thing is done. There is an extension to the periphery. The basic idea is like if the rexus extension is in one direction, the haptics actually should be oriented 90 degrees to it. So I'm not going to, if you permit me, I'll just show this here. So once the phaco is done, aspiration done, so the orientation of the haptics should be at 90 degrees to where the rexus has extended. So that is the take home from this. So ma'am said, for me, my preferred technique to prevent this is to decompress the back using a 2060 needle. So the trick here is you should not just go in with the 2060 needle, poke it and then aspirate. The idea is to have a negative pressure at the tip of the 2060 needle when the needle is in the anterior chamber. So as soon as you enter, you are aspirating. Otherwise, you touch it, many of the cases it just runs out to the periphery. So this is a trick. You aspirate and go in. I don't get that 30G needle in my OT, so I use a 26G needle. It works quite well. So there again, in the first video, you can see a small rexus being done and that being enlarged. The other one, I could do a large enough rexus to do a safe phacoemulsification there itself. So another technique is the technique that is popularized by our dear Mohan Rajan sir. I'm just showing it to you to show that it can be done. But I really don't prefer to do it. You just go in with full power phaco and cut the capsule and aspirate. In my hands, a 26G needle works with much more control. So that is my preferred technique, just to show that there is another technique that is possible. So this is this is another problem that you can face. Phacolytic glaucoma case. You start the capsular excess. The anterior capsule is very loose. You can see the whole bag is loose. So once you open the anterior capsule, the liquefied lens matter comes out, and what you see underneath is a small but a dense nucleus. So you do phacoemulsification, you try to keep it in the bag and do phacoemulsification. The posterior capsule is very loose. It has a tendency to come to the phacotip. So it is a bit dangerous. So my preferred technique in these cases is to put an IOL in the bag. So that gives you an IOL scaffold there. So when you do phacoemulsification, you try to chop, you get a funny feeling. This nucleus keeps on slipping on top of it. But you eat up a bit in the periphery, then you get a hold, and then you can do phaco. And you feel that it's more dangerous, it's going near the endothelium and all. But you use viscode. But here actually you have a chance to go much away from the endothelium, because you know that it is not going to catch the PC. So that way also it is much away from the endothelium. So to conclude, the definitive treatment for lens-induced glaucoma is cataract. But as the patient is being prepared for cataract, control the inflammation using frequent topical steroids and all possible anti-glaucoma medications. If it is phacomorphic glaucoma, and if you expect that you might have to put a primary iris clear lens, I prefer to do a YAC-PI. TRAB is not really necessary in these cases. Manual surgery, yes, it works. Use trypan blue, use Viscot or any other alternative. CCC, careful CCC, as I explained, slow motion phaco. Do you need a higher end phacoemulsification to manage these cases? Not really. Like whatever phacoemulsion that works for your other cases works really well in these cases. Postoperatively, use frequent topical steroids and anti-glaucoma medications to be continued till you really are sure that it is no longer required. See, these are two videos. The first one that I showed initially, that's the liquefied lens matter in the anterior chamber. So what is the other one? Is it a white cataract there? So is it really white cataract? You can see it actually is. See, I'm actually touching the PC there. It's actually liquefied lens material in the vitreous. Many times I've actually done a posterior capsular excess to drain it, but here I didn't do it, and it gets absorbed on its own. Just wanted to show something a bit different. So that is it. And again, this is another reason for my visit here to invite. And Habans sir will be taking over as president there. That's one more reason for you all to visit there. And it's a really nice place to be. And contact me, Gopal, Thomas Cherian also has come. Please come, don't miss it. Thank you.
Thank you, Dr. Srini.
Thank you.
And with this, we come to the end of this session, and I thank Dr. Maipasan Sazdev, Asif Shailwad, and Inder Monastagi, and all the speakers.
Thank you, Dr. Mohan. Yeah, so thanks, Dr. Arbans. So now, we have one more session. Those of you who are free can sit back, stay back, relax, and enjoy. And we definitely enjoyed the extended session of cataract surgery.